Alistair, thank you very much for those very, very kind words. I think probably my first word is how honoured I feel to be asked to give the Florey lecture at my old alma mater. I think one of the greatest honours one can have is actually to be asked back. So it took a long time, only 50 years, but it happened. And I'd also like to acknowledge people who've taken the afternoon to come, particularly colleagues of mine who we graduated together perhaps 10 years or so ago. But it's great to have you here, and as you probably know, it's the 50th anniversary of graduation of the I can't remember, the 1965 group, and so there'll be celebrations later on in the week. Earlier this year, I went to St Mary's Hospital in London and to visit a colleague, and you'll notice I noticed a little plaque here, and when I read it, it said, Sir Alexander Fleming discovered penicillin on the second-storey room above this plaque. And a few weeks later, I received a letter from Adelaide asking me to give the Florey lecture. So it seemed that it was all made in heaven. I think everyone knows the Florey story. I think that many don't know that it was 10 years after Fleming had discovered penicillin that Florey was thumbing through some old British medical journals, and this was in 1938, and came across the Fleming paper, and that triggered what became his life pursuit in terms of developing an antibiotic. And again, I don't think I have to tell you how many millions of lives were saved. This happened right at the beginning of World War II, and the influence of Florey is historical and unparalleled. Just on a personal note, in 1938, that same year, my father left war. The Nazis were invading Poland, and hopped on a boat with my mother and a sister, and arrived in Sydney, having finished medicine in Vienna several years previously, but that degree was not recognised by the Australian government because Austria was occupied by the enemy. And he started making cosmetics and peddling them in the country, New South Wales, when he received a letter from Adelaide University, inviting him to come and redo medicine, which he did. And in 1942, he graduated here, the certificate of Adelaide University. So we owe a lot to the University of Adelaide in terms of our family beings. And this is a photo taken, this probably explains how I got into diabetes. We went up to Wylam. My father was a BHP doctor, and he had my sister, myself, and my brother. And you can see that my sister and brother ended up in cardiology. They were technologically minded, and here I was with a bloomin' rocking horse, and that determined my fate, which subsequently, working with Philip Harding here in our residency, we did medicine together, and I did a little bit of diabetes then, and that was the first touch of diabetes. Well, the topic today is diabetes the greatest epidemic the world has faced? And we know there have been many other famous epidemics in the past. The Black Death plague, millions and millions of people died from that. However, we think that diabetes, certainly from a chronic disease perspective, along with obesity, now is likely to be the greatest epidemic in human history. Diabetes was very much a Cinderella disease when Phil Harding and I were working just up the road. Was it Flinders Ward? It was a bit of a Mickey Mouse disorder, and no one really knew much about it except you gave someone a jab of insulin. And it was really momentum developing around 2006, when finally the United Nations, the General Assembly, made one of the few unanimous decisions it's ever made in its history, and that was a resolution went through creating diabetes as an international public health issue. And as of then, November the 14th every year became World Diabetes Day, and governments were implored to activate interest and action against this growing epidemic. So, what's the situation now? Something like 1 in every 12 people in the world has diabetes. Something at the moment around 400 million, predicted to go to 600 million people within the next 10 years. If diabetes was a country, it would be the 3rd biggest country in the world after China and India. Every 7 seconds there's one person who dies from diabetes, and something like 5 million deaths annually. 1 in 9 health dollars in Australia is spent in diabetes, and it's something like 14 billion annually. This is several years ago. But in the United States, it's up around $612 billion annually. Even George Washington was actually worried about this prospective spend. As part of putting together the National Diabetes Strategy, or the recommendations to the federal government, which we've just submitted a few weeks ago, we had to assess the annual impact of diabetes in Australia. And I'm not going to give you the gory details of complications, but this summarises the number of hospitalisations, the cardiovascular and kidney disease complications, vision loss, which extends to complete blindness, end-stage kidney disease, and lower limb amputations, all attributed to diabetes. Most people think of diabetes in the context of an elevated blood sugar, but they ignore that it's associated with numerous comorbidities, one of which Alistair Burt's an expert in liver disease, the fatty liver. But another area, and just in case any of you go to sleep during the presentation, I thought I'd mention sleep apnea. You can see there is a very strong association now being discovered regarding sleep apnea. There's a very good group here in Adelaide, the Antics, Raoul and Nick Antic, are part of that group, on this problem. And these pictures just demonstrate to you, firstly, the high rates of motor vehicle accidents we see as a result of sleep apnea. And this jumbo jet of Nippon Airlines, the pilot fell asleep 3 or 4 times on a domestic flight over Japan. It's lucky the guy didn't go down with the plane. But the point about it is that diabetes is strongly associated with this and a number of other comorbidities. So just don't think of it as a simple high blood sugar. So our group has been one of the groups that's led the charge to provide the information that diabetes is this growing epidemic. And a lot of the information came from ours and other studies in the Pacific and in the Indian Ocean in Mauritius. And I just wanted to point out, this was a slide summarising the early studies in the Pacific, and you'll see that Ian Pryor from New Zealand, having a bit of fun here, sorry. Ian Pryor from New Zealand probably indicated from his studies the first sign that diabetes was affecting people in Polynesia. And there's subsequent studies in other areas of the Pacific, but note the highest rate of 19% came from a study out of Adelaide by Peter Wise, whose picture is shown there, which was really one of the first warnings of the very high rates of diabetes in our own indigenous population. As a result of having read about Pryor's work and knowing about Peter Wise's work, we took on a study in the Pacific Island, Central Pacific Island of Nauru, which you read about in the newspaper every day now because of the asylum seekers being looked after in Nauru. But we're going back now to 1975 when we undertook a study and found a rate of diabetes of 35%, which was the highest diabetes rate ever recorded up until then. 1 in 3 adults in Nauru had diabetes. At this stage, it was probably about 2 in 100 in Australia. So the Melbourne Age, our prestigious paper, cottoned onto this very quickly and ran this story about a Western killer in paradise. The trouble was they put my photograph there and they actually ignored the real story, which was the fact that diabetes was going to become a major killer. And now today, these are figures assembled by the International Diabetes Federation in various parts of the Pacific, and you can see that the rate we showed then, around 33%, was a forerunner to what has happened in the Pacific subsequently. I started to hanker for islands. Nauru isn't the greatest island to visit. It doesn't have any decent beaches, but we found Mauritius. WHO asked me to go to Mauritius because they thought they had a problem there of diabetes. And we undertook studies in Mauritius, which really became the harbinger to predict the global epidemic of diabetes more widely than the Pacific studies. And Mauritius is a very interesting situation because 1/3 of there's 1.6 million people, but it's ethnically diverse with Asian Indians, Creoles, and Chinese. And actually, these 3 ethnic groups constitute 2/3 of the world population. So even though there's a very small population in Mauritius, the actual implications of the study there have these wider range points. And we've undertaken studies since 1987 in Mauritius. We've just finished a study now in 2015. But these are the results of looking at diabetes in the years in Mauritius. And you can see from 1987 to 2009, almost a doubling of diabetes in that period, a 62% increase in that period. And so we then started to talk about, well, this is what's going to happen in India, what's going to happen in China. Well, here are 2 studies from India, one from 2000 and the year 2000, when the prevalence of diabetes was about 14%, and the same group of people studied 6 years later, and already there was something like a 50% increase in diabetes. So we now know, of course, that India has got one of the highest numbers of people in the world, as I showed in an earlier slide. But that's the process. This is a typical picture that you see in Jaipur and in various cities in India now, of course, the Coca-Colanisation of lifestyle. And the Herald Tribune, International Herald Tribune, ran this story, and I've just highlighted one point there. I'm concerned for virtually every country where there's modernisation going on because of the diabetes that follows. I'm fearful of the resources ever being available to address it. And that was a comment that I had been quoted in that particular article. And if we just look at China, what's happened in China? Virtually no diabetes in China in 1980, and going to 2009, there's almost been a 10-fold increase in the number of people, or certainly the prevalence. And it's the same story. The McDonald's in Tiananmen Square, you can see people lining up for their hamburger and chips. And of course, wouldn't you expect some people walking up the stairs or down the stairs in this shopping centre in Shanghai? Well, if you can see anyone, I'll give you $50. And so China and India have got huge numbers of people with diabetes, and The Economist ran this story. It was all about economics, of course, but in fact the contest of the century between China and India is really for diabetes more than economics. And you can see here that in fact in China now they estimate it's like 110 million people with diabetes, which is 5 times the normal population of Australia. So I think we have to agree there's an epidemic. So what about Australia? In the year 2000, after we were lucky enough to have Michael Wooldridge as the Minister for Health at that time, and his wife had diabetes, so it helped, we were able to get funding to do the first ever national diabetes study in Australia called AusDiab. And that study, looking at baseline work from a study undertaken by Tim Welborn, who actually was an Adelaide graduate, but he's from Perth, using their baseline data, then our data from the AusDiab study, where diabetes had shot up almost, well, greater than threefold, or exactly threefold, in Australia in that period of 20 years, and how obesity rates had almost trebled. So things were not looking good in Australia. And in fact, our study, the AusDiab study, showed for the first time there were 2 million people with diabetes, 1 million people with diabetes in Australia. And at this stage, while there's some arguments going on, because we don't believe, and I know Alex Brown doesn't believe the Indigenous community, we don't believe the ABS figures, we think there's about 1.5 million people in Australia with diabetes, and another 2 million with pre-diabetes at very high risk of developing diabetes. And every day in Australia, there's over 300 new cases of diabetes. Well, what about our Indigenous community? The rates of diabetes in our Indigenous community, firstly, in terms of risk, there's almost a 4-fold risk of Indigenous people developing diabetes compared with the European-based community. This is a comparison of studies undertaken by Karen O'Day, who was here at the other university. I think she's back in Melbourne now. But she's done a number of studies over the year comparing Indigenous rates with our AusDiab rates, which is shown here in gold. And you can see in 2 separate Indigenous communities these very high rates in comparison. And these fall-offs that occur, in this particular group don't represent less people getting diabetes. They represent excess mortality, more people developing diabetes, and that's contributing to what appears to be a fall. So that's not a happy situation in this prosperous nation. I like to show this picture because football fans like it. And these pictures here, taken back in the early 80s, this here is the 1958 Rovers Premiership Aboriginal team. When this was published, all but one were dead. And here is the European, the rich, the Collingwood Melbourne club. I don't know if there are any Collingwood supporters here, but they were all still alive. And again, I think this is another reflection of the enormous mortality differences between our communities. And we've been working in Alice Springs with Alex Brown and his team. We now know that the Indigenous people in Australia have some of the highest rates of diabetes in the world. They have the highest rates of end-stage renal disease, and in fact Alice Springs has the largest per capita renal dialysis facility in the Southern Hemisphere. It's not a record that we really need to be proud about. Well, hopefully all this is going to change. We have a very strong Indigenous health component in your new SAMRI Institute here. Some people call this the cheese grater, I think. I hope I'm forgiven for mentioning that, but it's a fine team led by Alex Brown. And Alex has recently received substantial NHMRC funding for a major project looking at determinants of complications of Indigenous people in South Australia, which will probably be the largest study ever performed in Australia. Has got a terrific team assembled at SAMRI, and I'm delighted to be a part of that exercise. Well, we've talked about the rises of diabetes in various populations, and I haven't shown you data from America or Turkey or other places, but some people say, well, have there been any falls in the rate of diabetes? Well, we know that during World War I and World War II, rate of diabetes did fall, but they were rather unique situations. But I mentioned earlier the island of Nauru, which was one of the richest communities in the world at the time, from phosphate, but they've now gone broke because the phosphates run out, and they're basically supported by the Australian government. And mainly looking after refugees coming on the boats, so to speak. And a study undertaken in 2004, and these are the data initially of our early study in 1994, you can see something like 50% of people in this age group had diabetes there. If you now look at this age group here, it's dropped almost a third. And as a result of the economic downturn in Nauru, diabetes rates are falling. So that's sort of good news in a way, but it's paradoxical. And the drivers of diabetes, and also similar situations happened in Cuba. Somehow the slide hasn't come up. So I'm now just going to look at the drivers of diabetes. You've heard all the bad news. And listed here are some of the major risk factors causing this diabetes epidemic. And I just wanted to highlight one of the major things I want to talk about is fetal programming and the effect of maternal and child health in this epidemic, which to date has been relatively ignored. We published the obesity rates in Australia in the year 2003, I think, and this was the Ages flyer that went out to all news agents. People were able to see we actually were in a fat epidemic. These data here just illustrate that something over 40% of people in Australia, adults, are obese. Of course, there is childhood obesity, and that in fact, if you look at the annual rates of diabetes, that people who are obese are 4 times more likely than normal people to develop diabetes. So obesity is certainly a major driver, but that's not all the problem is. Now, I just thought to introduce an element of South Australia. Here are the national rankings for obesity and physical activity, or physical inactivity. And you can see here that southeast South Australia, outback South Australia, and even Adelaide, the north part of Adelaide, rank certainly in the top 15 districts or regions or localities where obesity exists and insufficient physical activity, two major drivers of diabetes. So how can we prevent this? Well, Karen O'Day, whose data I showed you earlier on, undertook a very nice study many, many years ago. It was published in 1984, when she took a group of Indigenous people out bush for 7 weeks and measured everything before they went out and then when they came back, and was able to show that in that period of time they lost weight. Those who had diabetes had either got less or they lost their diabetes, their insulin responses improved, their blood fats improved, and their blood pressure improved. Now, some people claim that while Karen was asleep at night, some of them crept back into town to have a few drinks and a bit of food and whatnot. But overall, this was an incredible study. It was recognised worldwide as, you know, this is the way you go. And now people are using the Paleolithic diets to achieve similar results and making a lot of money out of it. This study was done in Finland, showing that diabetes, if you took people at high risk of diabetes and you put them on an intervention program of weight reduction and physical activity, that those compared with a control group, which is the control group, this was the diabetes development pattern, and these were people who undertook the intervention, you could prevent in 58% this happening. So again, there's some hope that something can be done. But one of the things that has sort of escaped the radar so far has been the importance of pre-programming. What happens to the baby in the uterus in terms of mother's behaviour? Now, I don't want mothers to be paranoid about it, because there are data emerging that even the father's behaviour can have an influence. But I think this phenomenon has very important implications in terms of preventing diabetes, that we have to act something like 50 or 60 years beforehand, not at the time when people are adults and they're in an obesogenic environment and they're putting on weight and they're not exercising. We can perhaps prevent a lot of diabetes, but by proper action at the time of pregnancy, pre-pregnancy, during pregnancy, and immediately post-pregnancy. And how did knowledge about this come about? At the end of World War II, during Nazi occupation still, there was a famine in the Netherlands. So the women had very low calorie diets, they're virtually on starvation diets, they had small babies. When someone studied 30, 40 years later these babies in adult life, they found higher rates of diabetes and obesity and high blood pressure. Now, this wasn't a one-off, because the same thing happened during the Mao famine in the late 1950s. The same story again, that children born at that time in adult life were more likely to have diabetes and obesity. A similar thing happened in Cambodia, but all of this thing emphasises the importance of pregnancy. This is a joke slide from one of my Indian colleagues. He took, mind you, it's the Allgate. This is a free advertising for the Allgate bed and breakfast. But the mother's womb is bed and breakfast to the fetus, and it has to be looked after during that time. And what we see is that there are certain things that can happen during pregnancy which can change the way the baby's genes, and that it includes diabetes, the high blood sugar, can change the way the baby's genes react in adult life in terms of the environment, being the obesogenic environment. And this is becoming a very important way of thinking about putting more resources into that area to address the epidemic, not just exercise and weight loss when people are already at high risk. And there are studies in animal studies now which suggest that these changes that happen to the baby are intergenerational, so that a baby born with a mother who has smoked or drank or such like, when she becomes pregnant, it gets transmitted, the defect. So I think this is going to be one of the very important areas in the next 10 or 15 years in terms of trying to stem the diabetes epidemic. Peter Luckman, who is the chief scientist for New Zealand, a brilliant scientist, has got this theory, the mismatch theory. And so, like in the Dutch winter famine in China, a baby in the womb was exposed to malnutrition and expected, when emerging into the world, would come into that environment. But they come into an environment where, in fact, there's plenty of food, etc., and there's this mismatch, which later on causes, the diabetes epidemic to run faster. So finally, what's happening in this country? So we've had, diabetes has had a pretty good run with the governments, but sort of lapsed off a bit. But our former Prime Minister, Tony Abbott, in his pre-election promise before the last election, said that he would activate diabetes with a new national focus, national task force. This took a long time to get there. Previous governments had dropped the bundle, so to speak, on diabetes, although Michael Wooldridge had really revved up the situation. And I think this belt buckle says it nicely. This is where we are at the moment with obesity, the major driver, and this is where we ought to be. And certainly in 2007, a joint government priority was diabetes prevention at the COAG meeting. I used to like this slide because when that photo was taken, a year or two later, the South Australian Premier, Mike Rann, was the only one that was still Premier. It just shows you the political life and the what can happen. Kevin Rudd didn't last long either. Kevin Rudd, quoting our data, of course, in 2008, said that by 2020, diabetes will be the #1 cause of disease in Australia, in men, and only second to breast cancer in women. And that's probably one of the very few true things that Kevin Rudd has said. We've just submitted to the federal government the new national diabetes strategy. It has to be passed by state ministers of health during November before we can start implementation, if implementation will happen. And these are I've just put them up here, an emphasis on the prevention of diabetes, promoting earlier detection of diabetes, reducing the occurrence of diabetes-related complications. In Australia, we have one of the best health systems, but it just doesn't work because it doesn't connect between primary health care and secondary and tertiary and whatnot. And there's a lot of good IT communication that could improve the system to the benefit of people. A very high priority is the Torres Strait Islanders and Aboriginal community, addressing diabetes in the culturally and linguistically diverse people, the aged, people with mental disturbance, mental disorders, reducing the impact in pregnancy, and much better systems. So on 2 months ago, Judy Moylan, myself as co-chairs, presented to Minister Lay the strategy, recommendations. She asked Ken Wyatt to be present, an Indigenous parliamentarian from Perth, very strong in the health area, and we're very pleased in the new Turnbull ministry, at least, that Suzanne Ley was reappointed Minister for Health and Ken Wyatt is Assistant Minister for Health. So if diabetes can't win in this environment, we are in trouble. So I just wanted to acknowledge the contribution of my wife to everything I've done. She's put up with me floating around the Pacific and in all these funny spots. And we're very proud of our two sons, Hendrik and Marcel, who have been very supportive. One's a paediatrician working in Indigenous health predominantly, the other a cardiologist. And they've been a great support to me ever since I left the Adelaide arena. So finally, these are the questions. Is type 2 diabetes the greatest epidemic in human history? Well, it is in terms of numbers, in terms of greatest cost, as I think I've shown you, and it's not over yet. And thank you.
So we do have some time for a few questions. Have you got the roving microphone? You need to use this one. Okay.
You could carry me.
Questions?
Yes, please. How much should pregnant women eat?
I'm not sure how to answer that. Can you amplify that particular question?
We mentioned the population studies.
Yeah.
Starving pregnant women.
Yeah.
Thank you. Starving pregnant women. Is there any science as to what the best nutrition is in pregnancy to prevent diabetes?
A healthy diet. I don't think, I'm not a nutritionist expert, but just sensible diet. I think the suggestion to avoid cigarette smoking, alcohol, and a sensible diet. Sorry, I can't amplify fast.
Hi, I was just curious. The numbers that are going to be increasing in terms of diabetes, how much of that is because we're detecting it better?
I think, look, that's a question that always comes up, and you're absolutely right to ask that, but a number of the studies, longitudinal studies like our Mauritius studies, etc., there are studies going on in Australia, for example. The outcome, though, of these studies has been that in countries where they're done, they test more regular. The GPs, it gets translated into people looking at for more often. But these studies where you see, say, in Mauritius, probably only half of those people knew they had diabetes. When we actually tested them, yes, we found it, but we don't talk about counting the number of people who have known diabetes. These studies all take into account the fact that they combine a group of unknown people as well. In Australia, there was one new case for every known case in the year 2000. It's now whittled right down to less than a half an unknown case, if you've got a half a person, half an unknown case. But it's a good question.
Thank you, Paul, for that interesting presentation. You put forward 10 or 12 admirable recommendations for the next 5 years. But how will you know whether you've achieved them or not? Wouldn't it help the situation if you said that you're going to increase or decrease by 10%, and then when you measure it in 2020, you could find out how well or how unwell it had been achieved.
So that's a very good point, and you should have been on our advisory group. No, because it was raised, and the government haven't asked us to do that yet, but the next stage, when the state ministers approve, there'll be an implementation plan. And we need, obviously, to set targets. The problem is that there have been targets set on public health issues. I'm sure a lot of people in the audience will know, in Australia, where they said they'd reduce obesity by 25%. Is that right, Gary? 25% or something? And it's been going up. So, yes, but that'll tell us, of course, that the strategies are failing.
Paul, the high incidence in these various countries, what is the incidence amongst those that maintain normal weight compared to those that aren't?
In general, weight is a very important indicator. In the Pacific Islands, for example, Samoa, Nauru, obesity is associated with much higher rates. But of course, type 2 diabetes has a genetic basis, and it's the environmental things like obesity that unmask it. So yes, you do get people in Nauru and Samoa who don't have diabetes, who maintain physical activity and healthy weight.
Half the rate or less?
It varies, but it would be about half the rate.
I think one last question from them. Yeah.
Hi, I've worked in diabetes for the last 30 years, and it seems to me that all of this relies on lots of different people coming together to create pathways of care that do connect between acute care and primary health care. And previously, when we had the big services with team management and that within the hospitals, there was lots of communication between professionals. Now that we've got primary health care, there's a lot of disjointing issues there. And I guess I'd like to hear what you think the new primary health networks maybe could offer when it comes to bringing those teams together with pathways of care that everyone knows about.
Well, I wish I had the pre-science to know what's planned. You know, we've gone from Medicare locals to primary health care. There's a very interesting story. Kevin Rudd was obsessed with reforming the hospital system, first and foremost. And when he went to the final meeting of health ministers in Perth to try and get through everyone together, he slapped on the table a $400 million plan for primary health care, pathways, etc., for diabetes, to get everyone on side. Not one person in the Department of Health knew that he was going to do it, okay? So he got tipped out about 2 months later, and Julia Gillard's government decided to save money, so they converted it into a $35 million pilot project, which the tender was won by McKinsey's, and I don't know if there's anyone here who took part in that. There was some activity in South Australia. That report on the McKinsey study is gathering dust at the moment in Canberra. Maybe something will happen, and that may have an influence on primary health care. But people haven't got their heads right. See, they think, the government think that all diabetes is the same. Now, in general, we don't believe type 1 diabetes as a specialist area should be pushed into primary health care away from the specialist people and whatnot. So there's still a lot of things to sort out in this country. And as I say, we know how to manage diabetes, but there's too much messing around with the system and poor communication, patients leaving hospital, going to the GP, there's no communication. The GP doesn't know the insulin was stopped or was started, etc. So I'm sorry I've given you a general view of pessimism, but Junie Moylan and myself are committed. If this strategy isn't enacted on, there'll be a lot of jumping up and down.
Thank you. I think everyone in the room will agree we've been treated to an outstanding Florey lecture this evening, one which has covered the origins, the impact and the potential prevention of what you've described as probably our greatest epidemic. So thank you very much, Paul. Now, before we close, I'd like to introduce Hannah Wardle. Hannah is a postgraduate student here at the university, a superb and talented young researcher. She's the recipient of 2 Florey-funded scholarships, and we're pleased to welcome her to just say a few words about what she's doing. Thank you.
Thank you very much, Professor Burt, and thank you very much, Professor Zimmet. That was an incredible presentation. I'm really pleased to be here tonight just to share a little bit about my research and why the support we receive as young researchers is really very important to the progress of our careers in science. I'm in the 3rd year of my PhD project at the University of Adelaide, and really I work broadly within the field of supportive care and cancer. I'm really interested in looking at some of the side effects of chemotherapy treatment because really they're looked at as an unavoidable and necessary part of cancer treatment, even kind of viewed as a bit of a trade-off for remission. Now, I'm really keen on changing this perspective by firstly increasing the awareness of this research area and also trying to reduce the impact that these symptoms have on the overall quality of life of cancer patients. So specifically, my research looks at predominantly gastrointestinal and neurological side effects of chemotherapy treatment and how the 2 side effects may be linked. My preliminary research has shown that the symptoms of diarrhoea, a not very pleasant side effect, and also increased pain sensitivity both seem to be linked to the activation of a particular immune receptor called TLR4. Now, if this is the case, this provides us with a really exciting opportunity to target TLR4 and hopefully treat multiple side effects of chemotherapy concurrently, which would improve overall patient care and obviously quality of life. So as PhD students, we are entirely dependent on securing grants, scholarships, funds in order to conduct our primary research. This can become very difficult because we're not obviously as competitive as early career researchers and also established academics. So as our career progresses, we do see improvements in our track records and we do become more competitive, but it still becomes very difficult and is very difficult and stressful to secure funding. And so this makes a career in science a little bit daunting for us. I'm thrilled to be the recipient of 2 Florey Medical Research Foundation scholarships, and these scholarships have allowed me to extend my work into TLR4 further. This has now allowed me to look at ways in which we can inhibit TLR4 and hopefully reduce the severity of these side effects we see associated with chemotherapy treatment, which will hopefully make cancer treatment a little bit more tolerable for patients. So I'm really here to say thank you for supporting the Florey Medical Research Foundation and to encourage you to continue doing so. Because it's support from you people that really make young researchers' careers much more enjoyable and viable. So thank you very much.